Can you hear me?
Oh, yes, we can hear you. That's outstanding. Perfect.
Great.
Okay, so I'm Joe Basha. I know we've seen each other once before on WebEx, but I wanted to introduce you to your co-faculty for this session, Dr. Lucas, Scott Lucas. He's here. I also wanted to show you our crowd. We're all here sitting around. I had to make everybody move from the outside in so you would see them. You didn't see a tunnel, but let's all welcome Dr. Perkins. And we are all really eager to hear what you have to say about this very troubling problem. So with that said, Dr. Perkins, the floor is yours.
Great, thank you. Well, thank you everyone for listening to what CDC has to share regarding our experience with NTM infections in general, and more specifically in relation to the national and international outbreak related to M. Chimera. So I did want to thank Joe for inviting CDC participation. I wish I was physically there with you all in Vegas, but instead I'm down here in Hotlanta. So let me start sharing here. And can you all see the screen okay? Okay. Great. So I wanted to first start talking a little bit about what non-tuberculous mycobacteria are in general and what their role is in the healthcare setting. So as you may all know, non-tuberculous mycobacteria or NTM are generally free-living organisms that are really ubiquitous in the environment and are species within the Mycobacterium genus that are not Mycobacterium tuberculosis or Mycobacterium leprae, which are commonly known to cause tuberculosis and leprosy, respectively. Now, NTM are acid-fast bacteria, meaning they have a wax-like nature to them and a nearly impermeable cell wall. The bacteria are generally found everywhere in the environment, oftentimes in soil and in water, and they're prone to biofilm formation. And we've noticed over time as the incidence of tuberculosis has been declining, where socioeconomic conditions have been improving, we're seeing increased frequency of isolating NTMs, and their relevance to human disease is becoming increasingly apparent over the last couple of decades. So NTMs do cause clinical infections, especially among those who are immunocompromised or have chronic lung disease. And most cases of NTM infections are pulmonary. However, 10% are extrapulmonary, so cause disease outside of the respiratory tract. These infections can be quite difficult to diagnose because of their indolent presentation and general low clinical suspicion. And as I'll share with you, there have been many outbreaks in healthcare settings, and oftentimes this is related to water contamination and water sources. So as far as NTM, as I mentioned, we're focusing here on the Mycobacterium genus split into M. tuberculosis and NTM. And there are more than 160 species of NTM. And typically we talk about rapid growing NTM and slow growing NTM. And rapid growing species begin to grow in less than 7 days, and you may begin to see culture growth on plates at 48 hours. And then there's the slow growing species of NTM. And these require at least about 14 days for a mature growth. And a few examples of slow growing NTM species are listed here on this flow chart. And one of the most commonly implicated species of NTM in the US is Mycobacterium avium complex, which typically are referred to as MAC species. And these, again, are most commonly found in the US. And this MAC complex includes Mycobacterium chimera. The most common species associated with healthcare-associated infections in general, however, are many of the rapid-growing forms of NTM species, such as M. chelonae, M. abscessus, and M. fortuitum. So NTM infections are typically pretty difficult to diagnose, as I mentioned before, and there's several reasons for this. One of them being that they typically present with very nonspecific symptoms. So fever, unexplained fever, fatigue, malaise, generally symptoms that could be attributed to many other chronic or infectious causes. NTM infections, as I mentioned, do tend to have long incubation periods, especially the slow growing forms. So the time between exposure to the actual pathogen and presentation of symptoms can be quite long, sometimes spanning months to years. So that makes it really low on the differential diagnosis of most physicians that are seeing patients with these infections. And additionally, these infections do tend to be difficult to diagnose because they require special tests. So your routine blood cultures won't pick these up. You need to order special acid-fast bacilli or AFB cultures. In addition to being difficult to diagnose, they're also very difficult to treat. Many NTMs are resistant to antibiotics. They require a long duration of therapy, again, months, sometimes up to a year of 2, 3, sometimes even 4 different antibiotics. So as far as clinical presentation of these infections, there are 4 real main categories in the way they present clinically. One being a progressive pulmonary disease, and this is the typical manifestation of NTM infections and tend to affect, again, those folks with chronic underlying pulmonary disease, such as chronic obstructive pulmonary disease or COPD, or patients who have cystic fibrosis. A second major category is superficial lymphadenitis. We see this a lot in children who present with cervical lymphadenitis, where the lymph nodes in the neck become infected, swollen, and inflamed, and oftentimes require surgical management. Another category of a clinical presentation is disseminated disease, and this is typically seen in patients who are really very immunocompromised. So the most common example here are patients with AIDS who present with disseminated MAC infections. And then the fourth major category is skin and soft tissue infections. And these are usually a consequence of direct inoculation, most commonly, for example, surgery. And this picture is a picture of a pediatric patient with a cervical lymphadenitis. So what is the prevalence of NTM in the US? The unfortunate answer is that we actually don't know because NTM surveillance is not, it's not a nationally notifiable disease. So we don't have a national surveillance system. That being said, there have been many efforts to try to estimate the prevalence of NTM here in this country using various registries, microbiologic databases in various states. And this is one example of a paper that tried to estimate burden of NTM in the US. And in this paper that was published in 2012, the authors tried to estimate the national prevalence using a nationally representative 5% sample of Medicare beneficiaries from beneficiaries between 1997 and 2007. And it included 2.3 million people. And they found that during this 10 to 11 year period or so, they found that the annual prevalence of pulmonary NTM infections increased from 20 to 47 cases per 100,000 persons. And that translates to about 8.7% increase in prevalence per year. And although we know there's geographical variation in the prevalence of NTM infections across the US, overall, there does seem to be pretty convincing evidence that their NTM infections are increasing in all regions of the country, both among men and women. So as I mentioned, we know that there have been healthcare-associated NTM outbreaks in the past. Most tend to be related to wound infections. And oftentimes these are in the setting of cardiac surgeries and plastic surgeries. Oftentimes we can trace the source of the infections back to water. We know, again, that NTMs are ubiquitous in water sources. And they get introduced into the healthcare system either through contaminated supplies, for example, contaminated injections, inadequate skin disinfection, or contaminated equipment such as needles. The most common cardiac surgery related outbreaks tend to involve contaminated prosthetic heart valves. And we've also seen in the literature cardioplegia solution that's been contaminated by non-sterile ice that was made using tap water. Another area that we've seen these outbreaks is when portable misting humidifiers are used in healthcare settings, which they're actually not supposed to be used in healthcare. And I'll talk about an outbreak that involved one of those in just a couple of minutes. So just again to reiterate what some common sources of NTM outbreaks in the healthcare setting are. A recent publication out of Hopkins actually was published earlier this year by Sudan Parrish, looked at different NTM outbreaks in healthcare settings over the last several years, and they really identified four major categories of sources for NTM infections in healthcare. And the first category would be devices. And I think we're all aware of the most notable device of late is the heater cooler device. And although the M Chimera in the LivaNova 3T devices is probably the most notable over the past couple of years, we have heard of other outbreaks that have had potential links to heater cooler devices. For example, in Mayo Clinic around 2014, they had a cluster of 6 cases of surgical site infections with M. walenskyii, which is a rapid growing form of NTM following cardiac surgery. And the authors did believe that these infections were potentially associated with a water system that was used with their heart-lung machines that once they eliminated, had no further cases. We also see infections related to surgical sources. And again, I mentioned plastic surgery, and we're seeing this a lot in relation to medical tourism. We have an increasing number of US residents traveling abroad, mostly to Latin American countries, to undergo plastic surgery procedures and are returning with severe surgical site infections related to these plastic surgery procedures. Most of the time, these are rapid growing forms of NTM, such as Mycobacterium abscessus. And these are difficult to detect because many times these patients are widely distributed geographically throughout the US and even across the world. So every couple of years, we continue to hear clusters of these. Again, another surgical source being eye surgery. A third common source of outbreaks are environmental water sources, such as hospital showers, especially. For example, we've heard of outbreaks of NTM central line infections among patients in oncology units. And although most of us are likely exposed every day to NTMs when we take a shower, immunocompromised patients, such as cancer patients who are receiving chemotherapy, and have medical devices such as central lines as a port of entry, are more likely susceptible to actually develop NTM infections when they're exposed to tap water and showers. And then we've also heard of outbreaks involving aqueous solutions, for example, contaminated ultrasound gel as well. So we're just going to go through a couple of examples of where we've seen NTM infections in the healthcare setting. This is an example of an ophthalmic cluster of ophthalmic infections following LASIK surgery that happened in Ohio a couple of years ago. So the Ohio Department of Health had heard of 2 cases of Mycobacterium chelonae eye infections in patients who had had LASIK surgery. And these surgeries were being performed at an ambulatory surgical center 1 day a month. And apparently the manufacturer of the laser device that's used for the LASIK procedure had recommended that the OR maintain about a 40 to 50% relative humidity while performing the procedure. So the facility decided to use a portable misting commercial grade humidifier. And what ended up happening is on further investigation, they tested the water actually in this humidifier, and it revealed that it did have the M. chelone, and it was the actual identical strain that was found in the two patients. So as you can see, water in the OR can always be problematic. And in this first picture, I guess on your left, you can see that in a LASIK procedure, the corneal epithelium is incised by the surgeon, which creates a flap, and it exposes the stroma underneath of the cornea. So it's exposed to pathogenic organisms that are there in the OR environment. And then the picture on the right just is a depiction of how water introduced into the misting humidifier causes the NTM to be released in the operating room and then enter the eye. A second example, and in an area of healthcare that we're seeing increasing NTM infections, is actually dental clinics. About a couple of years ago, we heard of a large number of pediatric patients who had come down with these cervical lymphadenitis NTM infections that I had mentioned earlier. And these were all cases of M. abscessus. And these kids were pretty young, ranging between ages of 3 and 11. And all these patients had had surgery at a single dental practice and had the same procedure, which was a pulpotomy. And a pulpotomy is essentially a root canal of baby teeth. And all these patients ended up becoming pretty ill. They all required hospitalization, and 17 out of those 20 patients had to actually go to the operating room and have undergo surgical excision of the infected lymph nodes. And on further investigation, we found that the water that was being used during the procedures, these pulpotomy procedures, had very, very high microbial counts, well above the limit that the American Dental Association recommends, which is 500 colony-forming units. And on average, when we tested the water at this clinic, their average colony-forming unit counts were over 90,000. So clearly the clinic was not maintaining or monitoring their dental water lines, and environmental testing revealed identical strains of M. abscessus in the dental water lines as compared to the isolates that were obtained from these kids. And this was not actually an isolated incident. Exactly a year later, so last summer, we heard of across the country in California of a very large cluster of children who came down with M. abscessus, cervical lymphadenitis infections following pulpotomy procedures. So dental clinics emerging as an area where NTMs are presenting. Another example that I've mentioned already is plastic surgery, which we've seen postoperative wound infections with NTM. Again, M. abscessus being the culprit in most of these situations. This was a report from 2014 out of Switzerland of 7 women who had underwent plastic surgery in Latin America and returned with these post-surgical infections. And many of the women had to undergo surgical debridements and revisions of their procedures. And although the exact mode of transmission was not identified in all these cases, the most likely cause of infections was, again, introduction of tap water, sometime either intraoperatively or during postoperative care, such as rinsing wounds with tap water or using contaminated injectable medications. So obviously NTM is an issue in healthcare, and naturally brings up the topic of healthcare water systems. I presented just a few examples of published outbreaks of NTM infections acquired in the healthcare setting, but that really represents probably the tip of the iceberg of what's really going on. We at CDC continue to regularly receive consultation from requests for consultation from health departments across the country for these infections. So we know that drinking water and water distribution systems in healthcare settings need a closer look by facilities. We know that NTMs in general are chlorine and monochloramine tolerant. And this is an issue because many healthcare facilities are instituting chlorine or monochloramine treatment of their water systems to treat Legionella, which is another bacteria that we see in the healthcare setting. But as a result, this has kind of selected out for NTMs, and we're seeing an increase, a proportion of pathogens in water being NTMs. NTMs also form biofilms, which make them extraordinarily hard to get rid of once those biofilms are formed. And they like to live in low nutrient environments, again, contributing to the difficulty in getting rid of these organisms. Just this summer, the Legionella group at CDC released a guide for facilities to implement water management programs to reduce Legionella and other waterborne pathogens. And this is just a quick schematic of an example of what of the different levels of water introduction in a building or facility system would be, and areas that need attention and targeting. So, there's a need to improve NTM surveillance so that we are able to pick up outbreaks more quickly and intervene more quickly. As I mentioned, national reporting of NTM is not mandatory at this point. There are a few states who have made NTM infections reportable, but that's really up to an individual state to implement that. So, prompted by the recent heater cooler outbreak, CDC, along with in partnership with other state health departments, most notably Oregon, where extrapulmonary NTM is reportable, we decided to try to make a standardized case definition for extrapulmonary NTM. So that if states do decide to make these reportable, they have a standardized case definition that could be compared across jurisdictions. And I'm happy to say that this case definition was approved by the Council of State and Territorial Epidemiologists earlier this month. And this will be the first step in trying to encourage more and more states to mandate reporting so that we can detect outbreaks more readily. And hopefully in the next 1 or 2 years, we want to move towards making extrapulmonary NTM infections actually nationally notifiable so that we can actually detect outbreaks. So in summary, NTMs are ubiquitous in the environment. They're difficult to diagnose and to treat. We have pretty good evidence that they are increasing in prevalence, but again, national data is still lacking. Traditionally, these infections have, again, affected immunocompromised patients or patients with chronic lung disease, but we are seeing that these infections increasingly among immunocompetent patients, which is concerning. And healthcare-associated outbreaks occur in a variety of settings, not just hospitals. As I mentioned, we see them in dental clinics, ambulatory surgical centers, alternative medicine clinics are just a few examples. And again, the source of outbreaks we can commonly trace back to water. And healthcare facilities really should consider water management systems to help curb these outbreaks. So that concludes the first part of the talk. I didn't know, Joe, if you want to take questions or we should move on.
Hey, Dr. Perkins. Yeah, let's go ahead and move on. I think the plan is go ahead and do your part 2, and then Dr. Lucas will do his part with you still in attendance, and then we can have a panel discussion and maybe get some really good questions asked regarding this problem.
Sounds great. Okay, so the second part of the talk is really focusing on one specific NTM outbreak, and that's one that I'm sure all of you are quite familiar with, and that's related to the heater-cooler devices. So I just wanted to give more of a CDC perspective and what CDC has done along the way since we first heard about these cases, and try to update you on our current efforts. So I don't have to explain probably how heater-cooler devices work with cardiopulmonary bypass to this group, but I just want to essentially emphasize here that Up until now, the thought was heater cooler devices really didn't have any patient contact, and for this reason, they've traditionally been considered low risk overall to patients. And again, you're all likely very familiar with these heater cooler devices, and they look simple enough from the outside, but once you open one of these up, you can appreciate the complexity of all the parts that are involved with functioning of the device, including multiple water tanks and electrical circuits and fans. So again, wanted to spend the majority of the remainder of this talk to really discuss CDC's role in the investigation from where we started to where we are now. So back in the summer of 2014, a year before the first reports of Mycobacterium chimera were being reported from Europe, there was an investigation in Greenville, South Carolina, that some of you may have heard of, that started to raise some concern about NTM infections related specifically to heater cooler devices. In this facility in Greenville, South Carolina, there were a total of 18 cases. The majority were cardiac surgery patients, but not all of them. But they all were M. abscessus infections. The facility did conduct a patient notification. And although heater cooler devices were on the list of potential sources of infection, they were never really implicated. The evidence wasn't strong enough to really pin them down as a source of infection. But the facility did implement the use of sterile water following this cluster. But the real first strong evidence linking NTM infections, specifically M. chimera infections to heater cooler units, came out of Switzerland, where they identified invasive M. chimera infections in 6 patients over a 4-year time frame. And this publication came out in the early summer of 2015. And all of these patients had open chest cardiac surgery. All of them had some kind of implantable device placed. And these investigators did look into possible water sources and came up with heater cooler devices. And we found in this cluster that patients were presenting up to 3.5 years after they had had surgery. So this was surprising. This was quite a long time after exposure. So shortly after that report, we received a call at CDC in July of 2015 from the Pennsylvania Department of Health. They had been contacted by WellSpan York Hospital in Pennsylvania regarding a cluster of NTM infections among cardiothoracic surgery patients. And actually these patients, there were 3 patients, I believe, that had presented to a nearby facility, and an astute ID physician who had recently read the article by Dr. Sachs out of Switzerland put 2 and 2 together and noticed, that these patients had this rare type of NTM infection, and had noted that all these patients had surgery at York Hospital. So this is how this cluster was initially identified. So upon learning this and knowing about the Sachs article, York Hospital immediately sequestered and replaced their existing heater cooler devices and all attached devices. The Pennsylvania Department of Health and CDC investigated the cluster through a field investigation to verify the outbreak and to determine the cause of the outbreak and hopefully prevent additional infections. I'm not going to go through this in much detail, but these were part of the investigation objectives and what was done out in the field. The field team did do direct observations. They reviewed the facility's policies and procedures regarding infection control in the operating room in general. There were efforts to look for cases through retrospective case finding. And we also conducted a case control study. Again, we knew that this paper from Europe suggested that these heater cooler devices could be the cause of these NTM infections, but we wanted to cast a broad net and make sure that we accounted for all possible risk factors and that we didn't miss anything. And we did collect environmental samples while we were there. So we decided to look first at the rate of NTM infections by surgery type. Again, we didn't want to pigeonhole ourselves into looking just at cardiothoracic surgery patients. And we calculated the rate of patients with NTM positive specimens per 10,000 surgeries by the type of surgery that patients had. And here you can see that we found that patients who had cardiothoracic surgery compared to other common surgery types had a much higher rate of NTM infections. So this just helped confirm our initial impression that these infections were happening more frequently among this population. And so we could narrow our scope a little bit more confidently. These are some just very basic results from the case control study. The use of cardiopulmonary bypass was, again, which is a marker for exposure to a heater cooler device, was significantly associated with an increased odds of being a case. And there was also a suggestion for a dose response relationship with the length of exposure to the heater cooler unit. As that increased, we saw an increasing odds of being a case or a patient with an NTM infection. But this only reached a statistical significance when the procedure was more than 5 hours. But we were limited by small sample sizes. So the field team also, as I mentioned, did a pretty thorough infection control assessment, reviewed the infection control policies and practices, and they overall seem to be appropriate, especially pertaining to water use and airflow in the operating room. But it became evident that the periodic updates that the manufacturer sent out regarding heater cooler device disinfection were not kept up to date. It was difficult for the facility to keep up with these changes and may have resulted in some inconsistencies between the manufacturer recommendations and the facility practices. So as I mentioned, the facility removed all 3 of their devices from service prior to the on-site investigation. So it allowed us to inspect some of the out-of-service heater cooler units, and you can see in this box here where we found biofilm on the tubing, which is submerged in the water reservoirs. And again, as a reminder, this water and tubing, as you all know, is a closed circuit, which actually never contacts patient or patient blood. And then just quickly to review our laboratory testing results, you can see here that all 3 case patients grew Mycobacterium chimera. These were the case patients for which we actually had isolates available for testing. And all 3 other heater cooler units were also positive for Mycobacterium chimera. And we were also lucky enough to be able to do some air sampling in the operating room where we had the heater cooler device running in a simulation exercise, and were able to demonstrate that there was Mycobacterium chimera in the air samples as well. However, other water sources, such as like the ice machine and the scrub sink, grew other types of NTM infections, but actually didn't grow any Mycobacterium chimera. So the preliminary findings of this field investigation and of our case control study were immediately shared with FDA. And this prompted FDA to issue a safety communication shortly thereafter for facilities using these devices in general. So again, the scope was all heater cooler devices, not specifically the LivaNova 3T devices. And as you are all familiar with these recommendations, they did include stressing adherence to current manufacturer instructions. Again, making sure to use sterile or filtered water. We've been hearing facilities had been using tap water in some instances. And then I think the most important recommendation that FDA had issued was to direct the exhaust away from the patient and to remove units with any signs of contamination, for example, biofilm. Excuse me. And the FDA also did recommend and encourage MedWatch reporting from facilities if there was any concern of contamination or patient infection. So on the heels of the FDA communications, CDC shortly issued a complimentary guidance in October of 2015 to amplify the FDA alert, but we also wanted to provide additional guidance to facilities and health departments on how to find patients that might have infection. So we issued some guidelines on how facilities can go about looking at their medical records to identify patients that could have been missed. And then right around the same time, the first case series was reported in Europe of 10 cases from Switzerland, Germany, and the Netherlands. and they estimated of about 1 to 2 Mycobacterium chimera infections per 1,000 patients undergoing open heart surgery. And when they looked at various hospitals across the region, 17 out of those 25 hospitals had detected M. chimera in their water systems. Um, and all of these surgeries involve prosthetic material, which seems to be a common theme in all the cases that we've heard of. But I do want to emphasize that we've also heard of cases where there was no prosthetic material involved. So those patients are also at risk, but likely lower risk. And the mortality rate in this case series was high at 50%. Shortly thereafter, in the winter of 2016, we heard of a second cluster of, at that time, about 3 cases at the University of Iowa. And the 2 cases that were identified here were actually found when the facility did the retrospective look back, as was recommended by CDC. And after that, the university took great measures to inform patients and providers of this risk. And as a result of provider notification, an additional case was identified. And the University of Iowa really took a great measures to try to mitigate risk to patients. What they did was actually try to move the heater cooler device out of the operating room and thread the tubing through a wall that they had their engineers built in the operating room that you can see here with a sliding door. So by moving the machine completely out of the OR, they felt pretty comfortable that they had removed risk to patients moving forward. So given the continuing reports and the published data, both epi and laboratory strongly linking these devices with M. chimera infections, the FDA convened an advisory committee in June to address many of these questions. I'm not going to go into much detail about the findings and what was discussed there, but the executive summary can be found online on FDA's website. But I think overall, and some of the attendees there included the manufacturers of the LivaNova device, as well as other manufacturers of heater cooler devices. But I think one of the messages that came out of there that was definitely relevant to CDC's work was that despite many of our outreach efforts, the awareness of these infections was pretty low, and we needed to continue to escalate in awareness across the clinical community. Then, shortly after, in the spring of last year, we got the first evidence out of Europe that these M. chimera infections might be related to a common source, mainly the manufacturer. One institution published that they did typing of M. chimera from heater cooler devices in 3 different countries. And they noted that they were almost identical to samples obtained from the manufacturing site, but that data wasn't presented in that report, but raised some concerns. And simultaneously, CDC was working with other academic partners, including National Jewish Health, which is a national NTM reference laboratory and has expertise in this area. And we had been working with them on whole genome sequencing to try to type the different isolates from patients and from heater cooler devices from both the Iowa cluster and from the Pennsylvania clusters. And what we found was that the sequencing pointed to concerns for point source contamination because whole genome sequence showed that these strains were highly related. So strains taken from heater cooler devices in Iowa were closely related to patients who had surgery in Pennsylvania. So this prompted CDC to go ahead and issue a safety alert. And I'll go into a little bit about what that health alert said, and also amplified FDA's safety communication to include specifically the LivaNova device. Many of you may have seen CDC's health alert, but it essentially advised any facility that was using these machines, whether or not they had contaminated devices or infected patients. We advised all facilities that had these devices to notify patients that they may have been exposed. And we gave some guidelines that they could consider going back to January 1st, 2012, given the incubation period that we had been seeing in the literature. And back of the envelope calculations would suggest about 600,000 patients would be have been exposed during this time period. So that's a lot of people. And up till this point, we have some preliminary evidence and reassurance that I would say about 3/4 of hospitals have kind of gone through with these patient notifications. And although the CDC recommendations were focused on patient notification of patients who had surgery in the past, we also encouraged facilities to do prospective patient notification. In other words, including this risk in informed consent prior to patients undergoing procedures with these devices moving forward. Again, as I mentioned, NTM infections are not nationally notifiable, so reporting is not mandatory, but we did ask health departments and facilities to report cases to CDC if they heard of them. I just have up here what we considered an invasive NTM infections. Again, we weren't focusing on pulmonary infections. We don't think that pulmonary infections are caused by this type of exposure. And of course, facilities should report all cases to FDA. I'm not going to go through the FDA recommendations. I think Dr. Lucas will probably touch on this in his part of the talk, but this is just a summary of the recommendations that were put out by FDA in October of last year. But again, just focusing on the fact that the strong recommendation was to point the exhaust away from the patient to decrease risk. And also to consider the risk benefit that we know these procedures many times are life-saving and we need these devices to conduct these surgeries. So to take that into consideration. CDC worked really hard on outreach. We had multiple calls with stakeholders, with American Hospital Association, clinician groups. We've held webinars with many participants, different professional societies. But you know, we've tried to really hard to get the word out, but are learning that there are still many providers out there that are unaware of this risk, unfortunately. We've also tried outreach for patients. We have a comprehensive website that's dedicated to this issue. We have tools for patients. We have sample letters that patients can take to their providers if they think they've been exposed, to help providers become aware of the risk. And we've actually heard of patients being diagnosed because they took one of these letters to their physician and said, I'm having these symptoms and I've had this exposure. We had press releases. We have a YouTube video, which has had a lot of hits that's targeting patients. And there's been quite a bit of media attention. I'm going to try to go through these next few slides really quickly so I can give Dr. Lucas some time to talk, but this is just a snapshot of our heater cooler website. Again, you can see many of the tools there. And I just wanted to quickly show, just turning to the device aspect real quickly. Many of you might have seen this, this video, but essentially this was an experiment that was done by the group in Switzerland to show how the exhaust of the device could potentially blow aerosolized particles of NTM to the surgical field. Let's see if I can pull this up. And here you can see the top row of images depicts the OR when the heater cooler device is oriented with the main ventilation exhaust away from the surgical field. And then the bottom row shows the OR when the heater cooler device is oriented with the exhaust towards the surgical field. And as you can see in the bottom picture, how alarming it is, the extent of smoke dispersion that's occurring right above the OR table. So this was a very rudimentary experiment, but I think shows clearly that there was quite a risk of these particles being blown to the surgical field. I also wanted to bring up a publication that I think just came out this week or maybe last week out of Canada where they reported their first 2 cases there. And I think what's really interesting about these cases are that both of these patients had minimally invasive cardiac surgery. Prior to this, in the US, most, if not all, of the cases that we're aware of had open chest cardiac procedures. So this gives some concern that potentially implantable device or prosthetic material that may be sitting on a Mayo stand could be exposed to these aerosols. And so consideration really needs to be given to directing the exhaust not only away from the OR table and the patient, but from the entire sterile field. Just wanted to highlight that various institutions have taken their, tried to take matters into their own hands while we're waiting for risk mitigation strategies from the manufacturer on trying to reduce aerosolized particles reaching the OR. On the left, you can see one facility put a box to hook up to a vacuum device to pull out any aerosolized particles. And then the one on the right shows the mitigation strategy that University of Iowa had done. And just last month, I've learned about this just this week, that LivaNova has introduced a device upgrade or design modification, and they're labeling it a 3T heater cooler vacuum and sealing upgrade. And they're working on rolling out this kind of retrofit country by country. It looks like they're starting in Europe, and they're working with each local jurisdiction's regulatory agencies to get approval. So it's not rolled out in the US yet. And it's essentially designed as a modification that can be added to the new and existing devices, which they say improves the internal sealing and adds like a vacuum system to decrease the risk of dispersion of these aerosolized particles. This is just what you can find on their website. What they are proposing is this aerosolized collection set. And it basically replaces the use of the overflow bottle and consists of a suction canister, which is labeled 1 up above, 2 pieces of tubing, 1 to the heater cooler device, which is number 3, and 1 over to the vacuum source line. And they suggest hooking this up to a hospital vacuum source or a freestanding vacuum source. And this is a schematic that they provide of what the setup could potentially look like. So more to come on that, I believe, as FDA continues to work with the manufacturer and get approval for this retrofit. So we have continuing opportunities, but challenges to work through. Again, we need to work towards our outreach efforts and, rely on all of you to help spread the word and try to understand hospitals' uptake of and awareness of recommendations by CDC and FDA. We're also working on trying to help providers treat these infections. From what I understand, they're very, very difficult to treat. They're not your run-of-the-mill disseminated MAC infections. And trying to track these infections, their efforts right now in exploring the case registry so we can understand the natural progression of these infections. And then these risk mitigation strategies that have been introduced by both the manufacturer and other facilities working on trying to assess the effectiveness. So that's all I have. I apologize for going over.